Welcome everyone to the first Lunch with Docs for HD. We're really excited to be launching this. I'm Sarah Jones. I'm with the Parkinson and Movement Disorder Alliance. And Melissa, do you want to introduce yourself?
Hi everyone. I want to really thank you all for joining us today. My name is Melissa Biliardi. I am from the HD Support and Care Network. We are a 501c3 public charity, and our mission is to help HD families find support and care resources for their HD loved ones. I'd really like to thank some other people, but Sarah, I think you have some introductions, and then I would like to thank some folks.
Absolutely. Sure. So we're really glad to be having this, and we're going to have these on a regular basis. HD SCN, HD Support and Care Network, and PMD Alliance partner for service delivery, and obviously collaborate with our other HD providers. And we're really grateful to the HDSA folks for sharing the information about this as well. So we have people from all over the state of Arizona and California, and perhaps even elsewhere, who have logged on for this. So, and I really also cannot say a big enough thank you to Teva for helping to support these. The support that you provide us allows us to be able to do these on a regular basis, and we're really, really grateful. So thank you so much for that. And go ahead, Melissa, and then I'll introduce Dr. Shprecher and let him take it away.
Awesome. Well, you know, I would like to thank Beth as well, Beth Gray and Teva Pharmaceuticals, for sponsoring our webinar today. And also, obviously, we need to thank Parkinson and Movement Disorder Alliance for hosting us on your Zoom platform. And a very, very special thanks to our incredible special guest, Dr. David Shprecher. And I want him to know that the time he's spending with us today means the world to us. HD individuals, caregivers, family members, and friends of our HD folks who are listening now and later. It's going to be archived, so we will have a lot more listeners afterwards. And Dr. Shprecher, your dedication to your profession gives us a great deal of very important, credible information, and what it does, it imparts hope to us all. So thank you so much.
Welcome.
Just so you all know, Melissa, you were done, right?
Yes, thank you.
Melissa and I talk all the time, so we kind of think we can sort of, we may be thousands of miles away, but we can kind of work together like that. So we're going to tag team this this webinar too. Just so you all know, you've been muted. That's just so that we aren't interfering with Dr. Shprecher's talk. And down at the bottom, Melissa has highlighted in orange the chat button. And that chat is where you can submit questions, and Melissa and/or I will read them to Dr. Shprecher. That way we won't get into people talking over each other. It's just an easier way to do this. But we intentionally choose this kind of a platform versus a traditional webinar platform because part of our intention is to bring the personal touch to this. We know that these diseases can be isolating, and these diseases make it hard to get out and to be with other people in community. And community and socialization is so important. So we intentionally chose this platform because it allows us to see each other and feel more of a personal connection than you might feel in a traditional webinar. So in that same way, we intentionally keep this pretty casual. Dr. Shprecher has done some other ones for us, and we intentionally want this to be casual and want it to be a conversation, not feel like a formal situation that is potentially intimidating. So without taking another minute of time, I want to introduce you to Dr. David Shprecher. Dr. Shprecher is an advisor for the Alliance, and he is the director of the Banner Sun Health Research Institute Movement Disorders Program. He used to run the Huntington's program in Utah, the Center of Excellence in Utah. And we're fortunate enough that he moved to Arizona, I want to say maybe a couple years ago now. And every time I have an opportunity to hear him speak, I learn something from him. It's mind-blowing. So I think we are so fortunate to kick off this series with Dr. Shprecher because he is a wealth of information. So I'm not going to talk for another minute, and I'm going to let you take it, Dr. Shprecher. Thanks so much. We're viewing your screen. I'm not hearing you. Oh, there you are.
There we go.
Okay.
I've unmuted myself. There we go. I just want to thank both of you for organizing this conference, and to say I've been really impressed with this platform that the Movement Disorder Alliance is using. It really makes it a lot more convenient for you as an audience to be able to meet, ask questions, but without having to travel. You know, we're a pretty big metro area, let alone pretty big region of the country. So I hope that you find this useful. My main goal today is to just give you a very basic overview to point out that while many of you have heard these words, these are words that you shouldn't be hearing from a clinician who's experienced with Huntington's or who's going to be involved in taking care of you or your loved one through the journey with Huntington's disease. Nobody should ever say there's nothing we can do. We may reach limits in what we can and can't treat, but there's still always something we can do. So many of you have been told you have Huntington's when you don't actually have symptoms. So first of all, I just want to step back and make sure we're clear when we talk about treatment of Huntington's today, we're talking about people who have symptoms that are either in someone who has a parent or a family member directly related to that parent, where we already suspect you could have inherited the Huntington's gene, and that you're having one of these three types of symptoms where we strongly suspect it's directly related to that gene. Many times you'll have genetic testing, but in some cases, if you already have the motor symptoms along with some of these others, we may already make a diagnosis based on one of your parents having had Huntington's. So the motor symptoms of Huntington's are what we currently use to say in someone who has the gene or had a parent with Huntington's that's at risk, say now you have Huntington's. You could be a carrier of the gene for many, many years, even majority of your life, and still not have the actual symptoms for Huntington's. And that's an important distinction to recognize, because there are many work situations where you may be doing just fine in the workplace, and it's important for you to recognize that you do have rights. And any large organization with 15 or more people, there is a law called the Genetic Non-Discrimination Act. They can't discriminate against you and either hire or fire just based on the fact that you have a family history of Huntington's, or that you're a gene carrier if you don't. You're a gene carrier if you don't have symptoms. So what are some of the first motor symptoms that might lead us to make a diagnosis to say, you know, we knew that you had the gene, now we actually see evidence that you have symptoms of Huntington's? One of the earliest things that we often see, people may feel a little bit more unsteady on their feet. They may have twitching, either tics, where it's kind of the same twitching movement over and over, or jerky, random movements that kind of flow from one body part to another. This is what we mean when we talk about the chorea of Huntington's. Other movements that have kind of a posture where people twist and hold the posture for a longer period of time is what the neurologist means when they say dystonia. There are a number of other movement disorder symptoms that can also appear, but the chorea and then mild unsteadiness on one's feet are usually the early motor symptoms. But early on, sometimes even years before someone develops these motor symptoms, people may notice changes in their thinking, for example, their ability to pay attention, process what's being said to them, plan ahead, multitask. Or they may notice cognitive symptoms where they're more irritable, they're more prone to depressed moods, anxiety, or what we call obsessive compulsive symptoms, where they worry too much about the same thing over and over. So all three of these are symptoms that we're thinking about in someone who's at risk for HD. And then as physician, particularly a neurologist, trying to diagnose, that's where we make the decision whether these symptoms are directly related to the Huntington's gene. So very early on, these motor symptoms may not be a problem. It's later on in the course that people may start to notice that the chorea has gotten worse over time and is actually making people a little bit more clumsy, prone to dropping things, prone to bumping into things. Or in someone who has a job where the movements really interfere, that's where we sometimes think about treatment sooner than we otherwise would. Over time, that chorea may actually decline. There may be less of it, and people can become slower and stiffer. So Huntington's is a little complicated because it can cause people to be a little bit slower and more rigid in their movement at the same time that they have involuntary movement. The other problems besides chorea are a little more difficult to treat. These can include problems with gait and balance, where people are more prone to falls, problems with coordination that aren't simply due to involuntary movements like chorea, and problems with pronunciation, speech difficulties, problems with eye movement, so it's harder to read and follow words on a page, and even problems later on with swallowing, so certain foods or thin liquids like water become unsafe to drink. But this is where a lot of what we do is referral, not simply prescribing medication, but referral for things like physical therapy, occupational therapy, and speech therapy. So that's very important to bring up early on when you're seeing problems with gait and balance, pronunciation, or swallowing, to make sure the right referrals are arranged. We don't have great treatments for the slowness or muscle rigidity, but that's because the treatments that work in Parkinson's disease for that don't work well in Huntington's, because the parts of the brain that would be responding to the Parkinson's therapies are also degenerating. So you're losing parts of the brain in Huntington's that aren't usually affected in Parkinson's. The involuntary movements, chorea movements, do have several treatments that can be helpful. Occasionally, doctors will use tranquilizers, muscle relaxants, or amantadine, but those aren't really well-established treatments. Another treatment that is commonly used is in a category of medicine we call the antipsychotics. And these have a whole wide variety of names like Haldol, risperidone, Abilify, olanzapine, aripiprazole, Shprecher. These are all medications that may be used for behavioral symptoms, problems with mood, irritability, anxiety, that might also calm the chorea. They haven't been very well studied, so the dosing isn't always clear. But many doctors will start with those if there's more than one symptom that could be treated by one medication. To just treat chorea, up until recently, the main treatment we had available was Tetra Benazir. That was approved in the United States in 2009 under the brand name Xenazine with an X. That medication just recently went generic. However, the price of the medication hasn't really come down very much. It's still very expensive. One of the problems we had in treating the chorea of Huntington's was that a lot of people taking tetrabenazine for the chorea, the involuntary movements, would have fatigue, excessive sleepiness, increased depression or anxiety, even problems sleeping. That could occur as we increase the dose. And so that really limited the dose that we could use. In May of this year, so just this year, a new medication became available thanks to research that was organized through the Huntington Study Group. When I was at the University of Utah, I had the opportunity to be involved in that research. This is a medication that's in the same category as tetrabenazine. It uses a special approach to slowing the way the tetrabenazine breaks down in the body, so somebody can get a very steady level of the active component of the medication. What seems to be a problem with tetrabenazine is the level of the medication may increase pretty quickly after you take a dose. And so that sudden increase in level may be what contributes to the side effects. So far with Austedo, with the studies and then our early experience with it, it does appear to have some risk of fatigue, but it's still lower than what we saw with tetrabenazine. And a lot of these other side effects haven't come up. What's really encouraging is the side effect of worsened depression has not come up. And that's important because depression is a very common problem that we face with Huntington's. Now, with the chorea, this is something that many individuals with Huntington's may not realize that they have, or they may not be able to acknowledge that it's causing an impact. So sometimes it's helpful when family members or caregivers also participate in appointments just to help decide if the chorea is really interfering either in everyday interactions with people or in everyday activities, for example, eating and drinking. Some people, when the chorea is severe, are even bumping into things and are in pain because of injuries from the bruising that's indirectly caused by the chorea. But Huntington's is not just a movement disorder, and this is where we need a whole team approach. So we may have a neuropsychologist involved to help decide what type of thinking problems is the person having. These aren't usually the kind of memory problems that you would see with Alzheimer's disease. These are more problems with multitasking, processing speed, where it takes longer for a person to process what's being said to them. So early on, a person may eventually make that decision to change the type of work they're doing or even apply for disability, more often in my experience because of these cognitive symptoms rather than the motor symptoms. This is because if you're in a work environment that requires that you multitask and you're no longer able to do that without making mistakes, this is where we can't necessarily make accommodations in the workplace that allow you to still continue in that same type of job. So that's an important thing to recognize when it's occurring, and that's where a neuropsychologist can be helpful in doing detailed testing to decide what type of work someone with early cognitive symptoms of Huntington's can still participate in. Later on, people really have problems planning ahead, but early in the course, they may even lose a little bit of insight or judgment and make some financial decisions that really aren't in their best interest. They may not realize the degree of their impairment with the cognitive symptoms or even how much their motor symptoms are affecting them. So again, that's where early on, trying to involve family or an advocate, even if you don't have close family, identifying someone who can participate in your visits with your doctor if you're an individual with early stage Huntington's is really important, because later on, you may lose insight about mistakes that you're making or insight about some of the symptoms. It's really important to identify an advocate early on that has your best interests in mind. Later on, one frustrating problem is people with Huntington's really slow down their processing speed. So I often see at support groups, if we're going to have a support group where everyone's doing a round table or circle, a discussion in a circle, we want to give time for people who have Huntington's to really process what's said and respond to a direct question, because it can sometimes take a minute or more before somebody actually formulates what they want to say and answers the question. So it can be awkward for them and for everyone in the group when we've asked a question, the people who are doing fine, so the caregivers or family members have already answered, we move on to the next topic, and then the people with Huntington's are trying to answer that question a minute or two later. So just an important thing to recognize with the cognitive symptoms when you're trying to run a support group or just spend time with someone who's got more moderate stage cognitive symptoms of Huntington's. Late in the course, people are still aware what's going on. They may still remember a lot, but because there's an impairment of language, and people may not, they may be so slurred in their speech or just not be able to generate the words, that's where we may have to adapt and try to come up with ways, like using a language board to help someone communicate. So they can still point to a picture and show you what they want to say, whereas it would take a long time to try to interpret what they're trying to say due to the slurred speech or difficulty generating the actual words. There aren't a lot of options to treat cognitive symptoms that are proven yet. There's none that are proven yet. There are some that are in studies. And so, the real important thing to recognize is you still can try to adapt to the problem. So the language board, planning ahead, accommodations in the workplace are all examples where we might do that. But also early on, someone with early stage symptoms, you might want to try to plan ahead to avoid having to multitask, or recognize that your loved one who has early stage symptoms is likely to already have some problems with multitasking. And using devices, planners, calendars, tools that are more widely available in the modern era to help you plan ahead to avoid mistakes, particularly with scheduling, is important. The other important symptom that may occur earlier than we recognize is the psychiatric or behavioral type symptom. For some people, their first symptom, while this is rare, can be what we call a psychosis. This means a hallucination or a fixed belief that isn't true. We call it delusion. This is rare, but important to recognize, particularly if there's a family history that sounds like it might be Huntington's. If someone has a lot of involuntary twitching movements and now has suddenly developed hallucinations, Huntington's might be on the list of possible causes. More often what we see is that problems like depression, anxiety, changes in personality, becoming more impulsive may be a first symptom. I think one of the great examples of that was a very mild-mannered individual who had a family history of Huntington's. One of his very first symptoms is he almost got in a fight at the gas station because someone jumped in front of him in the gas station line, and his wife had to really stop him. Very out of character, but just more impulsive, really lost that social filter. So one of by far the most common symptoms are depression and also perseveration. When we talk about behavioral symptoms, these are very common. Depression is sometimes hard to separate from apathy, which is just problem getting motivated to do things, a loss of interest in activities and spending time with people, whereas depression is periods of sadness, feeling excessive guilt, feeling like a burden to other people. This still responds to the same antidepressants that work in people without Huntington's. Another thing that's important to recognize is that suicide does occur a lot more often in people with Huntington's or even a family history of Huntington's than people without. And many times this is a spur of the moment, really impulsive decision, because remember what I've said a moment ago, people really lose that filter, that ability to step back, think about the impact of what they're about to do is, and they make a decision without planning ahead, thinking it through. And so there have been instances where people on the spur of the moment just feel upset. They'll run out into traffic, they'll try to jump off a bridge, they'll go for firearms. If you're able to plan ahead and avoid situations like that, but don't have difficult conversations, don't escalate arguments when anything is available where somebody could make an impulsive gesture like that is present. Really try to keep firearms locked up in the first place. Just be careful about the availability of weapons in the home. And if you as a caregiver really feel unsafe, there have been instances where there's really irritability or suicidal behavior, or someone's actually talking about wanting to commit suicide or actually having a plan about committing suicide, this is where admission to a hospital to get treatment with the right medications can make a world of difference. Very often, people will resist taking medication, not just for the motor symptoms of Huntington, but for the psychiatric symptoms. And they'll go a long time without treatment until it gets to be a real problem where they're too depressed or too irritable, or obsessive compulsive symptoms are out of control. So obsessive compulsive symptoms, the most common one is perseveration. People just keep talking about the same problem over and over. They may, when they have an appointment, keep worrying that they're going to miss the appointment, and they'll ask, when do we have to leave? When do we have to leave? Over and over for hours before it's time to leave for the appointment. Some people even seem to have a bowel or bladder problem, but it's really a perseveration, obsessive worry that they're not going to make it in time. And so they'll be going to the bathroom dozens of times a day to avoid an accident. So these type of perseverations are important to bring up. They might respond to treatments, medication treatments that help with obsessive compulsive disorder. So obsessive compulsive disorder can include all types of thoughts that are difficult to let go of. If somebody's fixated on a project that they want to do, and they spend too much time on that project, that's an example of a compulsion, or an obsessive thought. A compulsion is when people perform a ritual over and over to try to relieve anxiety. So going to the bathroom dozens of times a day to relieve anxiety that they're going to have an accident. All of these symptoms may respond to medications that are similar to the ones we use to treat depression and anxiety, the ones that work on the serotonin system. Irritability, when it happens, can be a serious problem. Some people, particularly young people with Huntington's, may destroy property. They may even strike out at loved ones or caregivers. This is something that often will respond to antipsychotic type medications, even antidepressants. Sometimes requires a combination of therapies. And this is where, if it's severe, we may need to get a psychiatrist involved, and it may be preferable that you try to plan a hospital admission. So identify what's the hospital where you feel comfortable that they're going to communicate with a Huntington specialist about what type of treatments to start, so that when you call, if you do need to call law enforcement to help you arrange a hospital admission, law enforcement already knows ahead of time that this is a patient that has a medical illness that causes irritability, and that they're not going to use excessive force. They're going to bring the loved one to that, directly to that center, that hospital that has an inpatient psychiatry unit that's appropriate for the age of your loved one. So in some cases, if it's an older individual, they want it to be geriatric psychiatry. But if it's a younger individual, it needs to be a place that has a medical psychiatry unit that accepts people with a neurological illness who are younger and won't be a danger to the older patient. The other thing that may come along with, and I know we had a kind of a good question that just came through, is what happens when, along with these behavioral symptoms, there's also a sleep problem? Many doctors will start with tranquilizers to help put someone to sleep, but then they wake up later on and they'll ask the same question over and over again, or they'll just be really anxious. And so it's important to bring up all the problems you're seeing, not just the insomnia, but is there anxiety, is there depression, is there irritability? Does someone have a fixed belief about something that isn't really true? And that's where the doctor involved might choose a treatment that helps with sleep that could also help with the other behavioral symptom that may be driving the insomnia, or kind of treat more than one problem with one medication. When someone has these fixed beliefs, the delusions that aren't really true, or actual hallucinations, while that's rare, that's where we may need to use the antipsychotic medications earlier on. And it may actually serve as a dual therapy, a therapy that also helps with the chorea type symptoms. But when we're taking care of you or your loved one with Huntington's, it's not just about medication. This is a team approach. So early on, we want to, again, really make sure to involve someone who can serve as an advocate for you, the patient, for your loved one. Also consider involving a social worker early on that can help you plan ahead about all the different resources you might need, the medical, legal powers of attorney that you need to arrange. This is where you might need to get advice of a lawyer who has expertise on medical, legal powers of attorney, estate planning. The other thing that we often see is people want to be able to stay home throughout their journey with Huntington's. And in most cases, we can do that until very, very late. And so people may have Huntington's symptoms for 10, 15 years or more and still be able to stay in their home. Because first of all, there are options with home health care. There's palliative care where you have nurses available on the phone to give advice. For a monthly fee, you can involve them in a way that's still affordable. And just keep an open mind about the option of home hospice. This is something where if someone has an advanced stage of their illness, doesn't mean that we expect them to pass in the next few months, but most hospice has a requirement that we expect that there's a good chance that you may pass from advanced stage of your illness within 6 months. Doesn't mean you can't hang in there longer or you can't have improvements and eventually bounce in and out of hospice care, but it allows a lot more direct help in the home and arranging to ensure that you're properly taken care of, your loved one's taken care of, has enough control of pain and other physical symptoms, constipation, drooling, swallowing difficulties, getting the right diet. So really ensuring better quality of life late in the illness and making sure you have the resources to do that. So I'd say keep an open mind about the home hospice option, especially if your loved one really wants to be able to stay at home as long as possible. Now, while it's important that you bring up all these different types of symptoms I've discussed today, there are instances where it may appear that the doctor treating the Huntington's just isn't comfortable or isn't familiar enough with all these symptoms to know how to address them. That's where getting a consultation with a Huntington specialist can be helpful, even if you have to travel a long distance, perhaps once or twice a year to get that advice, and then involve the local doctor in that, in prescribing the medications. That can be a helpful option. Ours is one of several centers in Arizona that has a multidisciplinary clinic where we have a neuropsychologist, memory and movement disorder specialist neurologist, as well as a social worker. And most of the Huntington's programs that you'd be considering would have that. Other examples in Arizona are the Mayo Clinic, Barrow Neurological Institute, Muhammad Ali Center here in Phoenix, and also the University of Arizona in Tucson. The University of Utah does have a Huntington Center of Excellence, and I expect that other programs in Arizona will be applying for that status in the future. Another example of a center recognized as a HTSA Center of Excellence is also in Denver. We have 2 centers now in Denver. What differentiates a Center of Excellence mainly is that there's not only all of these services that I brought up, but Huntington's research going on and the availability of genetic counseling. Genetic counseling is really important to have available for people who are at risk for Huntington's and are trying to decide if they're ready to receive information about whether they're actually carriers of the gene, so pre-manifest carriers. So that's one of, I think, the main limitations on some of the up-and-coming centers that are trying to become centers of excellence, is trying to arrange support for that genetic counseling expertise. So another question that came through was, what can happen if the symptoms go untreated? And I've definitely seen people where they truly have chorea, symptoms that aren't bothersome. The psychiatric symptoms are still being managed without medication, but if we go a long time without treating the symptoms because the patient is resistant and then the caregiver supports that decision, I have seen occasional instances where the depression becomes severe and we worry about not just quality of life, but risk of suicide. The obsessive compulsive disorder can become severe where a person just can't leave the home because of hoarding. They can't throw stuff out. The house actually becomes unsafe. They may just spend inordinate amounts of time on obsessions and compulsions. And the irritability can become dangerous where they may destroy property or become dangerous to be around. The motor symptoms could also cause physical injuries. For example, if the Huntington's chorea is severe. So that's where, on rare occasions, we've had to arrange a hospital admission just to get someone tuned up with just the right medications to get the psychiatric symptoms under control, and then if they're really severe, the movement disorder symptoms as well. So there have been instances where we have to arrange an involuntary admission to the hospital. It's rare, and in most cases, we really can and should involve both the patient and their caregiver, their advocate, or family member in the decision about what treatments to take and what to avoid. Those are good questions. I think the bottom line is, again, people have been told this, and it's frustrating for me when I hear this, that this is an incurable illness and therefore there's nothing we can do. There are a lot of things we can do, not just to manage the symptoms, but to plan ahead and make sure that the patient lives their life on their own terms, maintains as good a quality of life as possible despite the illness. And we should never give up hope for better treatments. Even if we don't find a cure during your lifetime, there have been new treatments that have recently become available, and we're very optimistic there will be new treatments that become available through participation in research. So, another plug, besides making sure that you always get the best possible treatment, is keep an open mind about participating in research. The more people get involved in research, and the sooner they do that, the sooner we'll have better treatments for the symptoms of Huntington's, and hopefully someday a way to slow or even prevent progression of the illness entirely. So I really appreciate all of you having me. I've listed my website and also the Facebook page where I'll also post a link for this video on, and then the YouTube channel for the Movement Disorder Alliance will have this video posted on. So I'm going to wrap up and just open for questions. I think Sarah explained you can just speak your question or you can type it in and then she'll share that to me. Thank you.
Dr. Shprecher, thank you so much for spending this time with us. I do have some questions that came in aside from the chat, and it's really great that you were able to see the chat and answer those questions. Do you have a minute for a couple more questions?
Sure.
Awesome. Well, first I want to ask you too, are you doing clinical trials at your place of work there?
So my former place of work, the University of Utah, has been involved in a clinical trial testing a possible new treatment to see if it's effective for the irritability of Huntington's disease. So that's an important clinical trial I want everyone to be aware of. There may be support for travel available to participate in that study at the University of Utah in Salt Lake City. The other important study to be aware of is called Enroll-HD. That is a registry where any family member, those with or without the gene, whether you know genetic status or not, and even healthy caregivers who can participate as controls, and then of course people who do have Huntington, can all participate in getting as much information as possible about the natural course of Huntington in comparison to people without it, with and without the gene. That registry is recruiting here in Phoenix at the Muhammad Ali Center, held at the Barrow Neurological Institute. My center, as well as Mayo Clinic Arizona, are sites for the Huntington study group. And as new trials start, either of our sites may become involved in hosting the study for Arizona. So we're kind of in a holding pattern right now, just getting our Huntington study group site up and running since I moved recently from the University of Utah. So no active studies here at Banner Sun Health Research Institute.
Well, I'm looking forward to that clinical trial for irritability. That's going to be a good one. Let me ask you a couple questions. First one was, in your professional opinion, what is the #1 most important symptom to get a handle on with medications in the early stages of HD?
So when it occurs, things like irritability or delusions are really important that we don't hold off on treating. So it's not super common that we see severe irritability or actual hallucinations or delusions, but when they occur, those would certainly be really important to treat. Same is true when depression is severe, when someone actually has suicidal thoughts or behavior. Those are others that really we need to act early on and address. Now, I mean, the other symptoms, though, I'd say there's no one symptom that is the most common. I'd say perseverations, depression, and chorea are among the most treatable symptoms. So when they're impacting a person's everyday quality of life, there are treatments available, so we should consider them.
Awesome. Here's another question. Can treating one symptom help to improve other symptoms?
Yeah, so can treating one symptom help with other symptoms? Absolutely. So sometimes treating the irritability or other symptoms where we might use an antipsychotic, the antipsychotic may also help with the chorea symptoms. And vice versa, if we're using the antipsychotic for the chorea, it might help with other symptoms as well. When we're choosing a medication that is an antidepressant, anti-anxiety medication, that might also help with insomnia. And sleep problems are another very common symptom in Huntington. So we might choose a dual therapy for sleep and something else, or dual therapy for chorea or other psychiatric symptoms.
I just had another question real quick. What do they treat perseveration with? Is there a treatment
so the most
for that?
common, good question. Most common treatment for perseveration. Can you still hear me okay?
Yes, we can hear you.
Okay. Yeah, my Zoom.
Uh-oh, we lost you. I think we just lost him, Sarah.
I think actually he just took off his slides.
Okay, there
so
you go.
Oh, there he is. Okay.
You hear me now? Okay.
Yeah, there he is.
Okay, so for perseverations, the types of treatment are medications usually that we call the serotonin reuptake inhibitors, kind of like Prozac and Zoloft and sertraline. Some will use similar medications like venlafaxine, Effexor, Cymbalta. And in some cases, we'll combine with an antipsychotic. The other one that's used when it's really severe, but at the risk of more side effects, is called clomipramine, also known as anafranil. Among the serotonin boosting medications, sometimes Luvox, fluvoxamine, some people respond better with that. So you often see your doctor kind of switching medications around. If one's not helping, we'll switch to one of the others in a different category.
Now, are you using a guideline for these medications, or best practices, or algorithms?
Yeah, great question. Yeah, so there are some guidelines and best practice algorithms that are constantly being updated and are available on the Huntington Disease Society of America website. There's a clinician guide that summarizes the latest guidelines there. And it's available in both an electronic format as PDF or as a book that clinicians can order. So something that doctors don't always realize is, you know, if they really want to take good care of their patients in the 21st century, they can look stuff up, they can order books. So even if you're the first family your doctor's taking care of with Huntington's, if they really care and have the bandwidth and the time, they can order the book. They can even download it. So there's no excuse for saying there's nothing we can do.
Kind of like Google for doctors.
I mean, you know, there's a reason we call it continuing medical education, and it's so much more widely available now than it used to be, thanks to the internet.
Another question. Do you think that there are more people with Huntington's than we had originally thought?
I think awareness has been raised somewhat thanks to the internet, thanks to Huntington's being taught more often in schools. Not sure about medical schools or, for example, in residency training, but at least in schools. I mean, Huntington's taught in biology classes a lot more now than it used to be because of the advances in genetic research, and it's, you know, it's more widely known. So I think there's a little more awareness than there used to be. Sure, there are people out there that have Huntington's and you know, that just go undiagnosed for a long time. There was a great example of that. I think NPR had a webcast of a program where it was kind of a Dr. Jekyll, Mr. Hyde type story, where it was actually a doctor who had a profound change in personality and was admitted to a forensic psychiatry unit after he killed his father. It turns out the father had Huntington's, and now the doctor had Huntington's, and that's why he had such a change in personality. It took many years before he was actually properly diagnosed. So there definitely are cases out there that go undiagnosed for a long time. But thanks to your efforts, efforts of authors and journalists, awareness has really improved.
Hallelujah. One more question. Can you explain the difference between Tetra Benazir and the new medication that's time released? What is that difference?
Yeah. So the difference between the Tetra Benazir or Xenazine is, and the new one called Austedo, is basically what happens with Austedo. There's parts of the Tetra Benazir that are substituted with heavy water. So it's not radioactive, it's not toxic, but it's a form of the hydrogen from seawater that's a little bit heavier, and so it takes the liver longer to break down the active component of the tetrabenazine. So you have a steady level of the active component. You don't have a sudden rise in levels of active medication right after a dose with Austedo that you see with tetrabenazine. And that, we think that's why the side effects we're seeing with Austedo are actually much better than we expected. So when we did the study, we were actually really surprised at how only fatigue was the only thing we saw, and that was the only thing that was more than a placebo, inactive medication. But it's still maybe 12% versus more than 20%, as much as 25% of people had fatigue, almost 25% had sleepiness with tetrabenazine in the early trials. But the other problems that we saw with tetrabenazine, like insomnia, worsened depression, worsened anxiety, restlessness, even worsening of the slow movements or muscle rigidity, those are things we haven't seen so far with Austedo.
Mm-hmm. Would some of the peaks and valleys be a lot more drastic with the tetrabenazine?
Yes, there are more peaks and valleys in the level of the active component of the medication, which is also why tetrabenazine is usually dosed 3 times a day. Austedo is usually twice a day.
Very good. Sarah, did you have any other questions?
This has been just incredible. The information, as usual, that you provided. I'm so excited. We had about 24 people who joined us, and I also want to mention that Tessa Sweep, his social worker for family and community services with Banner Sun Health Research Institute, is also joining this call and is available. So, you know, we're just really fortunate to have physicians like you and the many physicians that really are dedicated to improving quality of life and, you know, enhancing the everyday experience of people who are dealing with movement disorders. So we can't thank you enough for you taking your time. And again, for Teva, you know, for supporting this. It means the world to us. Melissa, do you want to mention really quickly your online support groups?
Yes, so we have See Me support groups for HD individuals and also for the care partners. And our HD group is meeting every Wednesday at 12 noon Pacific Standard Time, 3 o'clock, of course, Eastern Standard Time. And if anyone is interested or knows someone that might be interested, please have them contact us directly. And you can find us on Facebook. You can find us on our websites, HDSCN, that's H as in Henry, D as in David, scn.org. Go to support groups and all the information is right there. One more question that I did have for Dr. Shprecher, I'm sorry, I forgot to ask. Do you treat juvenile Huntington's? We've talked about Huntington's, but now juvenile Huntington's seems to be popping up more often.
Yeah, so I have had a few patients over the years with juvenile Huntington's. It is more challenging to treat because while adults with Huntington's have a lot more chorea, juvenile Huntington's usually causes more slower, stiffer movements, what we call Parkinsonism, and there can be really early learning disability. So, you know, a lot more challenges in trying to adapt to the physical limitations, but also the cognitive problems. We also have a movement disorders neurologist here in Phoenix who recently joined Phoenix Children's Hospital. His name is Michael Kruer, K-R-U-E-R.
Fantastic.
Michael Kruer is probably one of the best doctors to consider in Arizona for a juvenile Huntington's patient. He had several patients before he moved here from North Dakota.
Wow. Okay, great. Thank you so much. Dr. Shprecher, you've just been so fabulous with all this information. I can't wait to share it out to the community that were not able to be with us today. And Sarah, thank you so very much for offering this wonderful platform for us to use.
Well, we're